So chief complaints, Mrs. R, a 63 years old homemaker from Gudiyatham, who presents with the following chief complaints: high-grade fever and loose stools for the past 2 days, abdominal pain for the past 5 days, vomiting for the past 1 day. So with this complaints presented to casualty. So a short history of presenting illness and course during the hospital stay. So she came to casualty with the above complaints in shock, recurring triple iono drops. So she was intubated in casualty, admitted in ICU on 19/10/23. So she was diagnosed as to have septic shock, acute pancreatitis with MOTS, AKI and CKD, severe metabolic acidosis. So in ICU, she completed 7 days course of meropenem and doxycycline. She also received 2 SLED on 20th of October and 24th of October for oliguric AKI. So she was extubated and improved significantly. So she was shifted back to ward on 25th of October. So 2 days after shifting to ward, she had fever spikes and tachypnea. So she also recovered some noradrenaline transiently, which was tapered and stopped. So blood cultures were sent. She was empirically started on injection polymyxin and linezolid because she was shifted from ICU. So she also already received meropenem. So on 13th of October night, the patient was found had to have non-breathing. She was found apneic, but pulse was present. So she was developed respiratory arrest in the ward. So she was intubated and kept in the ward for 1 day, and the next day she was shifted to ICU because of lack of ICU beds. So during the respiratory arrest, pulse was there, so we did an ABG. It showed a pH of 7.04, PCO2 81, PO2 of 203. So we suspected she had developed some respiratory arrest. She had developed buildup of carbon dioxide. So because of this carbon dioxide buildup, she was unresponsive. So while shifting to ICU, her pulse was 51 per minute, blood pressure 152/76, respiratory 26 per minute, saturation 99% because she was shifted after intubation. So she was on ventilatory supports, SIMB mode, P8, pressure support 12. CNS, GCS was only 2T/15. Pupils are reacting to light, gag reflex present. Other examination was within normal limits. Actually, her chest was very much clear. Only problem, she was found apneic. So after shifting to ICU, the next day she was extubated. Only 1 day she was in intubated state. So next day ABG was like it almost became normal. PCO2 of 30 or PO2 of 374. So we looked into the causes of this sudden onset respiratory arrest. So most probable cause might be, we looked into some metabolic abnormalities. There was no hypokalemia, no hyperphosphatemia. So only this potassium is 3.7 at the time of arrest, but there was hypocalcemia. Calcium is ionized calcium is only 3.26. So in a lab value, it was 5.14, and the corrected calcium was 6.5. So other causes, we looked into some drug interactions and some neuromuscular blocking agents like that we looked into. So while going into the literature review, and we found out the side effect of the drugs, we found the most probable cause for this patient causing respiratory arrest is polymyxin. So polymyxin and colistin are bactericidal agents that disrupt the outer cell membrane of gram-negative rods. So used for infections like Enterobacteriaceae, Pseudomonas aeruginosa, and Acinetobacter baumannii. In our settings, we're mostly using this drug for Acinetobacter baumannii. So neurological manifestations. The neurological manifestation side effects of this polymyxin will cause dizziness, muscle weakness, facial and peripheral paresthesia, visual disturbances, vertigo, confusion, hallucinations, seizures, partial deafness, ataxia, neuromuscular blockade. So the incidence of this polymyxin-related neurotoxicity is reported in literature is 0 to 7%. Paresthesia is the most common neurotoxic side effect. So mechanism of action is it's actually inhibit the action of acetylcholine in the neuromuscular junction, prolonged depolarization, consume calcium. So our patient also has hypocalcemia with corrected calcium only 6.5. So it also induces histamine release. So it's a non-competitive blockade. So the main risk factor to be associated is the secondary to polymyxin is renal disease, acute or chronic. So our patient also has a chronic CKD, while presentation the patient's creatinine was around 5. But actually the polymyxin doesn't need renal adjustment, but in the case of CKD patient, there may be accumulation of polymyxin leading to neurotoxicity. So the possibility of neurotoxicity is directly related to the concentration of polymyxin active form in the blood. So it's a case series of 11 patients. They found that those patients receiving polymyxin can develop neurotoxicity up to 45 days. So this neurotoxicity develops usually from 1 to 26 hours after giving polymyxin, but typical timing is 1 to 3 hours. Actually, our patient received polymyxin for 2 days. Actually, 4 doses he has received. So risk factors that may potentially trigger the development of neurotoxicity include the combination of polymyxin with other muscle relaxants, anesthetics, sedatives, narcotic drugs, or corticosteroids. But our patient was in ICU. Our patient was in ward during this respiratory arrest. So he was not on any other muscle relaxants or sedatives. So the treatment of polymyxin related neurotoxicity is usually supportive, including controlled ventilation and discontinuation of polymyxin. So our patient also, we discontinued polymyxin and started on other drugs, actually minocycline. So the next 2 days he improved, he was extubated, he improved significantly. So other antimicrobials which can cause this potentially this neuromuscular blockade includes aminoglycosides, tetracyclines, polymyxin, clindamycin. So our patient received polymyxin for 4 doses. He also has a previous CKD history was there. So clearance during that time was only 14. So he had hypocalcemia also 6.5, probably due to consumption by, actually the mechanism of action of causing this neurotoxicity include consumption of calcium also. So landing point, respiratory muscle paralysis is a rare and potentially fatal side effect of these antibiotics like aminoglycosides, polymyxin, etc. So we should have a regular review of drug interactions. Any other drug you're adding, we should look into the drug interactions of these newly added drugs, as well as routine this renal and neurological assessments. Thank you.
Sure. This polymyxin-induced respiratory failure or neurotoxicity, you see a lot in hemat wards. So when they start polymyxin, initially the first dose especially, they're very careful about it. Medicine wards, we hardly see this. But anyway, just be careful about this. You can see. Any other comments? Any doubts?
Yeah, but we thought that actually we started correction for hypocalcemia also, but this also might cause hypocalcemia. It's polymyxin. Yeah.
Next day ABG also, your calcium is lower than the first day ABG. Was she extubated then?
No. This is second day, third day we extubated actually. 2 days he was in the.
The second day is worse than the first day. What was the cause of hypocalcemia?
Sir?
What was the cause of hypocalcemia in your patient?
We are suspecting might be due to this.
Everything would have, this polymyxin would have precipitated less respiratory failure in already hypocalcemic patient. I think you should evaluate for the hypocalcemia as well.
The latest calcium.
Lost calcium is actually check.
There have been a laryngeal spasm, cycle,
but chest was clear at that time. No strider, nothing was there.
Have evidence of PCOS being very
80. She was found not breathing actually.
Now, even if you have bronchospasm or anything, the patient will not be breathing anyway. They would have tired out by the time you saw the patient has crashed already. So again, evaluate for the underlying cause.
Awesome.
We cannot label a single rare etiology as the only cause of certain life-threatening condition.
integrated in the ward or
In the ward. Yeah, card call came and indicated the patient. Yeah.
Sure. So thank you very much for your presentations. Very well done. Just one feedback. When you present your history and examination, at the end of history and examination, you should summarize, give a clinical summary and clinical syndrome, and then ask for differentials to people. So it will be easier that way.